Good morning, everybody. Welcome to our Unshamed California Learning webinar series. My name is Leslie Alfaro, and I'm so excited that you were able to join us today. Today we have a webinar against moral failing, the social determinants of OUD, and I'm so excited for you guys to hear this one. I get to work with both Megan and Jody, so I know that they're going to do great. But before we kick off into that, just do a little run through of the campaign. Up until now, as most of you know, Unshamed California is an evidence-based 10-month educational campaign. We work with the Department of Healthcare Services, and we officially launched in March. So this will be our 5th month, so halfway through. And we have so far gotten a lot of really good support. If you are interested in sharing your story, or if you know someone who wants to share their story, please feel free to email us. We always are happy to talk through the process with anybody. We can answer any questions, talk about the process, whatever that looks like, or whatever you might want to know. We are happy to do that. So just email us at unshamedca@shatterproof.org and we will get back to you. I know that we talk about our social media accounts often, both here and on our newsletter. So if you're not following us, please do that. We both have an English account and then our Spanish account, Somos Unshamed CA. Here's just a tiny snapshot of some of the comments that we've been getting. It's been really exciting to see just the positive support and the people within our accounts also supporting each other. We've had some really great collaborations with some influencers, and so far, we've had a lot of them supporting the comments as well. So it's been really great throughout. I'm not going to read them all for you, but if you haven't done that, take a look at some of the comments we've been getting. They're great. If you've missed any of our stories so far, you can check all of them out on our website. So if you just go over to unshamedca.org, you can click on stories, and then you'll see all of the stories. We recently released our first Spanish story from Mike. He has an incredibly moving story. So if you haven't checked that out, even if you don't speak Spanish, it's translated on there, as you'll be able to learn a little bit about him, as well as all of our other story sharers. And as always, plug for next month. Are you registered for the series? If you're not, the webinars happen the 3rd Thursday of the month, and our next one will be on September 21st, where we'll be talking about using social media for narrative change. So a great place for anybody who is interested in changing the story around addiction or any other sort of public health campaign. We'll be talking about that. Just general housekeeping, we do have our Q&A section as well as our chat function open. So if you have any questions, feel free to drop those in there throughout. We'll have someone keeping an eye on them. We will also be emailing out both the recording and the PowerPoint presentation at the end of this. So keep an eye out for that. And then we also have interpretation services available. So if you need this, or you would prefer to listen to this in Spanish, just go ahead and click that interpretation and you can watch it there. We always have closed captioning. So if that is something that you would like, click that button at the bottom and it should pop up for you. Without further ado, I'm so excited to welcome both Megan Helmo and Jody McIntosh today. Megan Helmo is our Director of Healthcare here at Shatterproof on the STIPA team, and Jody McIntosh is the Director of Community Engagement. I could spend probably 45 minutes talking about how amazing they are, so I will just kick it over to them and let them tell you guys a little bit more about the work that they do. Welcome, Megan and Jody.
Awesome. Thank you so much, Leslie. It's great to be here. I just want to make sure everybody can hear me. You're good? Great. Okay, so Jody and I are so happy to be here today. Good morning to everybody on the West Coast. We're going to talk about the social determinants of health, the social determinants of substance use disorder, certainly applicable to opioid use disorder, which I know is the title that Leslie presented at the beginning here. My name is Megan Helma. As Leslie mentioned, I am the Director of Healthcare here at Chatterproof. So what that means is for now, I'm working especially on one program where we are developing an intervention to reduce substance use disorder related stigma in healthcare providers. And I've worked on health equity in a number of different settings and topic areas during the course of my, we're going on, what year is it? Like 15-ish, 16-ish year career. So really happy to have the opportunity to work in this area and on stigma reduction in substance use disorder. I'm going to kick it over to Jody to introduce herself.
Good morning, everyone. Thank you, Megan. I am Jody McIntosh. I am the Director of Community Engagement. And what that means is I am pretty much leading the community efforts of our anti-stigma campaigns in Georgia, Kentucky, parts of Pennsylvania, parts of New York, and soon to be in Michigan. And it's great work. Absolutely love what I do. Like Megan, I do have quite a few years under my belt working in public health. And so it's something that I'm super duper passionate about. I'm sure that Megan and I could spend like hours and hours talking about this topic. It took us some time to kind of condense it down into just these things. But yeah, we're super excited to be presenting to you today and look forward to the conversation that we'll have.
Excellent. Cool. Thanks, Jody. So let's get started. As mentioned, today we're going to be talking about the social determinants of health and how those relate to substance use disorder, which they absolutely 100% do. So the learning objectives for today. So really what we hope you'll get out of this webinar, what you'll leave knowing. First, define the 6 social determinants of health categories. Those vary a little bit depending on the model you're looking at, but we're going to look at a framework that is pretty well accepted in the field. Understand substance use disorder SUD-related inequities, and understand how the social determinants of health relate to inequities, or how they drive inequities related to substance use disorder. And then we hope that you'll leave knowing about some resources that you can visit if you want to learn more about social determinants of health, SDOH, health equity, and substance use disorder. So we'll end on that. And we do want to make sure that we have an interactive session as much as possible. I can see the light in my space is a little weird. Please excuse that. It'll probably go in and out. I have no way of stopping it. I have no idea what happens with my camera. Yeah, we hope you'll interact with us. We are going to ask you to put some things in the chat. We're going to have a couple of polls for you all to participate in. And if you have any questions throughout the webinar, please put them in the Q&A. We'll make sure to get to those at the end. We won't make anybody come off, on camera and say anything with their voices, but we really do count on that interaction in the chat. So we'll be really excited to have you participate with us. I should also say that, Jody and I work nationally, and we work in many states other than California. So you all who are on this webinar are the experts in what's going on when it comes to inequities, social determinants of health, and what you're seeing on the ground in California. So when you do participate in the chat, we'll be really eager to hear, what you're seeing with your own eyes every day. So you're the experts when it comes to the California specific pieces of this. All right, so to get started, let's start with a little vignette. Silas. We're going to come back to Silas at the end of this presentation. But let me read a little bit about him. You can read on your own too, but just for accessibility, I'll sort of do it with my voice as well. And we want to think about what's going on for Silas that might be contributing to his substance use disorder, in this case, opioid use disorder, and influencing his ability to get any help that he might want or need for that SUD. So Silas is a 25-year-old Black male. He lives alone in Temecula, California. Grew up in a Christian household. He still occasionally attends church with his family when he can. But his parents live in San Diego because he recently, he's in Temecula now because he had moved away from San Diego to look for more affordable housing. He works in the service industry, plenty of jobs in the local vineyards near Temecula. He really loves trying new recipes, going to farmers markets, trying out the local restaurants. Clearly, he's a foodie. He finds that he doesn't have a ton of relationships outside of his family, and he has struggled to make new connections since moving to Temecula. He will occasionally make the trip to San Diego to enjoy the beach, but traffic can be a deterrent. Silas does have an opioid use disorder. 3 years ago, he went through a back surgery and he began misusing the opioids prescribed to him for pain management at that time. So let's get started right away with a bit of interaction. Would love for you to share in the chat what you think is going on for Silas. Again, what might be contributing to his opioid use disorder and what might be affecting or impacting his ability to get the help he needs or wants. I'll give you about, 20 more seconds to 30 more seconds to throw some things in there. Great. So lack of support and isolation. Absolutely. That's a very clear given that he's recently moved and he's further away from his family. So could be we don't know much about his sexual orientation or his first language, but absolutely those could be impacting. Making connections, pain from back surgery recovery. Isolation, I'm definitely seeing isolation here. Excellent, so already touching on some of the possible social determinants of health and of the opioid use disorder specifically that Silas is experiencing. So we'll come back to Silas, like I said, maybe come up with some additional things that might be impacting him after we've learned a little bit more about SDOH and health equity. So let's get into some useful terminology. First of all, health disparity. A health disparity simply is a difference in health outcomes. Okay? I want to really highlight the difference between a health disparity and health inequity, because these terms are used interchangeably a lot of the times. And some people really feel like they should have the same meaning, but it's useful to call out the slight difference here. A health inequity is also a difference in health outcomes, but it's a difference in health outcomes that it reflects some kind of injustice. Okay, so the cause of the difference in health outcomes is coming from some injustice that occurs in our system, our systems, our society, or social relationships, etc. Health equity, sure, it's the opposite of health inequity, but it gets a little more specific than that when it comes to the definition. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. What I really like about this definition of health equity is it uses their highest level of health. So what that says to me is that everybody's definition of health, what it means to them, and what it means for them to achieve their highest level of health is individual. That is something that they should be able to determine themselves. It's not a universal definition of health, okay? But it does mean that everybody has the fair and just opportunity to attain whatever that is for them. And then SDOH, or social determinants of health. We're going to get more into the details of this, but for now, the SDOH are the factors affecting health that are shaped by social, economic, and institutional policies and practices. So if we move on to a little bit more about the definition of equity, I always find this image by the Robert Wood Johnson Foundation to be really useful. Because another set of terms that get interchanged a lot are equity and equality, and they are very different. So equality is where everyone gets the same regardless of if it's needed or right for them. So you can see in the image here, we've got folks crossing the street or attempting to cross the street, and there's a curb. Some people can get down that curb. Some people can determine whether it's safe or not to cross the street, whether they're at a crosswalk, et cetera, and others can't. Equity if you see an image on the right, everyone gets what they need, understanding the unique barriers, circumstances, and conditions of each person. And so clearly we have a situation where the folks that may have had a more difficult time crossing this particular street in the first image have what they need to do that and do that safely. And the other people can still also cross the street, the people that were able to cross it before. This set of images you probably are familiar with, and the Robert Wood Johnson Foundation has put out a series of these equity versus equality images in the past. This one is the most recent one, and it was crowdsourced actually. So professionals and people in the general public were able to actually contribute to what they thought this image should look like now to illustrate the difference between equity and equality. I think that this is just a really great concept to keep in mind as we talk about health equity and we talk about the social determinants of health. Everybody needs something different to attain, again, their highest level or optimal level of health.
Megan, can I just add one thing here that
Yes,
I feel
please.
like I just had a little bit of an epiphany just now. Not only are, like with these two images, not only are we seeing some structural changes, so we see like the curb is now broken and there's visuals and there are also audio signs, but we see that the first two people have like traded places. So there was a structural change, but there were also some individual changes that had to be made in order to move from equality to equity.
Thanks, Jody. Yeah, absolutely. And so if we I'm going to stay in this like Robert Wood Johnson world because they've done so much health equity work, but we can move to this quote. Dr. Risa Lavizzo-Mori was the CEO of Robert Wood Johnson Foundation for a long time, during the time where they really made this like turn to health equity work. And she said that health in the US is a tale of two starkly different realities. The better off and well-connected are not only in a stronger position to receive care when they need it, but they also start off with advantages that have a tremendous effect on health in housing, employment, stress levels, food security, social capital, and more. You can see what she's doing at the end of that quote. She's starting to list off social determinants of health. And I really love this quote as well, because we talk about, hey, I'm sick, I need to go get care. And if I am a person who is, as she puts it, better off and well connected, I'm going to be in a good position to go receive that care and receive quality care, or care that's appropriate and responsive to my needs. But I also, if I am, again, better off and well connected, I'm starting in a completely different place when it comes to my health, and I may have less need to even seek out that care in the first place. So there are various levels at which health equity comes into play, and health equity inequities, how they start or where they start. So, social determinants of health. This is why we're here. Let's talk about them. Here's another definition, a little bit more filled out than the one that we saw earlier. So the social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So what does that mean? So if we look at a pretty well accepted framework for the social determinants of health, we see that they're broken down here into 6 categories. Like I said earlier, there's different models for this. Some people will add certain things or delete certain things. But I think that this model is by the Kaiser Family Foundation is a really good place to start. So we have economic stability. You can see in the rectangle here below what is some of the things or examples that are included in that. So do you have employment? Do you have stable employment? Do you have significant debt? Does that impact your ability to afford things, including healthcare? What are your medical bills like? What job type? I personally would probably put into this category as well. It could go into community. If you are somebody who works a more manual job, does that impact your health? If you're working around contaminants or chemicals, does that impact your health? Things like that might go into the economic stability category. Neighborhood and physical environment. What kinds of green spaces do you have in your neighborhood? Is it safe, or do you perceive it as safe to go out and enjoy those green spaces, get some physical activity, be able to walk around? We know that place significantly impacts people's health down to the zip code, and we can, there's plenty of data to back this up. So neighborhood and physical environment. Education, that is certainly schools in any given place, community, but also vocational training. What opportunities are there, access is there to higher education, post-secondary education? Do people have the chance to access quality education that allows them to attain certain goals if education is part of those goals? Food, so food security, access to healthy food certainly has a big effect on our health. Community safety and social context, this is where we see that social isolation factor that people were bringing up with Silas earlier a ton. It also has to do with policing, has to do with what different kinds of support systems are in a community, whether it's a church system, if there's like a YMCA or Boys and Girls Club, that would be, you know, a place where people might be able to go to receive some of that social support or be around folks that encourage behaviors that might be healthier, quote unquote. And the healthcare system, this for me is the best sort of, what's the word, illustration of social determinants of health. We have 6 categories here, and only one is about health care specifically, right? Because all of these things impact our health, but certainly the quality of the healthcare system, what kind of coverage people are able to access, can they access culturally responsive and respectful care, vastly impacts our health. I want to make one note about the social determinants of health as well. A lot of people think about social determinants of health and sort of the negative impacts and how we can, like, some of these things have on people's health and how we can make those better or change those so that those negative impacts are ameliorated. I think it's really useful to think about SDOH in the sort of on the positive end of the spectrum too. So think about what assets exist for people and communities in these categories of social determinants of health or strengths. Think about what's going well for people already, maybe a social support system, and build on those when we're doing public health interventions, and certainly interventions that have to do with substance use and substance use disorder. So let's do a poll. I think that you can vote twice. If not, just vote once. We're going to pull it up here. Which 2 categories of social determinants of health do you think affect substance use disorder the most? And we'll do about, 30 seconds. There's no right answer here. Go ahead and vote. Whenever we see, a good number coming in, Leslie, maybe now we can sort of pull up the results. Should be able to see them. Excellent, thank you. So can everybody see those results, or is it just me? Out of curiosity. Well, I'll just say them. Thank you for the thumbs up there. So yeah, we've got a lot of people voting for neighborhood and physical environment. Absolutely. It's going to have a massive effect on substance use disorder, community safety and social context. Definitely the healthcare system. Great. So really across the board here, nothing for education. I think that's okay. But yeah, so what I see here though is a spread between the categories, the social determinants of health categories, and that is absolutely the case, that all of these would be impacting substance use disorder. So another framework for thinking about social determinants of health, and especially public health interventions to address them, is this upstream, downstream framework. And this I know is a bit small, so we won't spend too much time here, but suffice to say that we can do things at various places in the stream, quote unquote, to try to advance health equity, try to affect social determinants of health, and try to improve people's experiences when it comes to getting care for substance use and substance use disorder. So starting all the way upstream, developing strategic partnerships, advocacy to address social inequities along class, race, gender, et cetera, lines, institutional inequities. So this is things that these are things that corporations and businesses do. The laws and regulations around us that might be impacting our health. A great example of this is, for example, how we know that tobacco companies have purposefully targeted communities of color, and specifically Black communities. That is a practice, that is an institutional practice that drives health inequities between, in that case, the Black community and white communities, for example. Living conditions, so our physical environment, economic and work environment, social environment, service environment, tons of things in there. We can do capacity building, community organizing, civic engagement to affect the social determinants of health. And then you can see we're getting now really further downstream, and this is where a lot of us are doing work. And it's equally important as these things that we can do upstream, the direct work with people to, for example, reduce risk behaviors. So that might be individual health education, to treat their substance use or substance use disorder, case management, direct healthcare and medical practice, social work practice, et cetera, might be addressing that. A lot of work we think about and a lot of public health practice has certainly been more downstream. In a state like California, there's a lot happening upstream, which is great as well. Suffice to say that we should be doing work everywhere, right, along this sort of stream of public health practice to address health inequities. The next slide is really just another illustration of this. You can literally see the stream and some examples of strategies and tactics that are used along the way. But I think if we go down to the downstream part of this particular visual, again, you can see providing clinical care and actually introducing medical interventions. That's all the way downstream, treating individual patients or people. And again, this next slide, a similar sort of illustration, just in a different way. You can see that upstream, we're again talking about addressing social inequities, programs and initiatives to do that, programs and initiatives to address institutional inequities. Living conditions are considered more upstream, maybe they're midstream, I don't know. And individual level factors where we're directly working on preventing overdose or reducing overdose, or preventing, addressing polysubstance use, for example, intentional or unintentional. That is the work that's happening downstream within the individual people. But all of this work upstream can also affect what's happening with individuals, and those are the social determinants of health. So let's do 2 more polls. First, where are you in the stream? So we're probably, a lot of us, working in multiple places in the stream, upstream, midstream, downstream. But if you were to say, to bet where you spend most of your time, where would it be? Well, let's close this one and see what we got. Oh, wow. Awesome. So cool. So we have a lot of people working upstream in this group. I think this is the California effect. There's just so much incredible work going on there, and such a diversity of work going on. in California. We've done this in other states and you don't see that quite as much. Excellent. And then let's do one more poll. It might turn out kind of the same, but say you were given $10 million and you could use it to develop your ideal initiative or program. Where in the stream would you put that? Where would you want to be doing that work? All right, let's see what we got. Cool, so it changes a little bit. Some folks, I think, went from upstream to maybe downstream. I don't remember the exact distribution before, but we still have a lot of people really wanting to focus upstream. This is really cool. Great, so I think we've got a pretty good basis of social determinants of health equity. Now I'm going to pass it over to Jody to dig in a little bit more into the background of all of this. Go ahead, Jody.
Thanks, Megan, and thank you for all that background. So now we'll be talking a bit about substance use disorder and social determinants of health equity over time. Again, this is a portion that we could have spent a whole other presentation on. So this is a very quick overview. I haven't touched on everything, but feel free, if there are other things that are coming up in your mind as I'm going through this, feel free to drop them in the chat. And so I just want to highlight that there might be some stigmatizing terms in these descriptions just based on the laws or different kind of campaigns that were happening at that time. They may not be a reflection of the Unshame California campaign. So when we think about specifically opioids, they started back in the 19th century during the Civil War. That's when morphine was the only pain relief drug on the market. And so it was used to control pain specifically for wounded soldiers. And it was also heavily prescribed to white women for various ailments. So some of the social determinants of health that we're seeing popping up here are like employment, income, healthcare system. And the reason why this started to become an issue is that there was addiction rising as people were starting to suffer from withdrawal. Then we go into the 1860s. We see Chinese immigration in this country, which also came with some racial bias. So while the Chinese immigrants were building the Transcontinental Railroad, opium was used as a remedy for work-related injuries. And this led to the Chinese Exclusion Acts. In the late 1890s, introduced morphine. So that was the non-addictive wonder drug. And it was used for cough relief. It was described as being safe for children, believe it or not. And then in 1914, we had a Harrison Act. And there was just a series of act after act after act for quite a few years. But the Harrison Act was the first act that put a tax on morphine and heroin. And it pretty much forced doctors to register these certain drugs with the government to prevent doctors from over prescribing them. So this is where we see like the first formal regulation on drugs. In the 1924 Heroin Act prohibited manufacture, importation, and possession of heroin, even for medicinal use. And so that led to this black market of heroin, mainly in big cities. So that was during World War II in the 1940s, and really just changed the face of addiction. So remember, we started off with it being for like wounded soldiers, white women, and then we had some racial bias against the Chinese. And now we're moving into this black market that's only going into mainly the cities, big cities. And we know that the makeup of the big cities are a little different. And we start to see the criminalization of substance use. So in 1951, the Boggs Act, which imposed mandatory minimum criminal penalties and prison sentences. And we know that these have been extremely controversial, extremely problematic, as they disproportionately affect people of color, specifically Blacks and Latina populations. And then the 1970s, we see the infamous war on drugs, and America's public enemy number one is kind of the message that is pushed out. That came with another set of just law after law, a lot of criminalization, a lot of involvement in the carceral system for many folks who were substance users or who were involved in dealing these substances. In the 1980s, we see a rise in the HIV epidemic. And this is actually the first kind of introduction to harm reduction, where we see folks who are really trying to save lives without a abstinence-only kind of policy, but really how can we meet people where they're at? And injection drug use is what's considered a high risk factor for HIV. In 95, that's where OxyContin came on the scene, and that was marketed as less addictive. So we see some kind of similarities to what we saw with the morphine. And in 99, that's where we started to see that rise in prescription opioid overdose deaths. And in the years after to present, we've seen a consistent rise in heroin overdose deaths. From 1999 to 2020, more than 500,000 people died from an overdose involving any opioid, including prescription and illicit opioids. 2013 is where we started to see the rise in synthetic opioid overdose deaths. So we might touch on that a little bit today, a little bit later on as we're talking. And then in 2021 to now, we have the national opioid settlement. And so what this has opened the door for is funding for abatement of the opioid epidemic. And pretty much all the jurisdictions in the country have some form of funding from this if they opted into it that allows them to provide programming and resources and treatment to truly address the opioid epidemic in America. So as I mentioned before, the recent uptick in substance use disproportionately affects people of color. So between 2020 and 2021, drug overdose death rates increased across all racial and ethnic groups, but increases were larger for the American Indian and Alaskan Native or Indigenous, Black and Hispanic people compared to their white counterparts. And so just explaining what we're looking at here, that gray line at the top is the American Indian, Alaskan Native line. So you can see it's the highest and it also increased the most. And then the blue line underneath is for the Black population. The orange line is for the white population. Green, Hispanic. The light blue is for the Native Hawaiian Pacific Islander, and then the yellow line at the bottom is the Asian population. And this uptick, I know this data says 2020 to 2021, but this uptick has continued even more recently with the data that we have available to us. This graph depicts who did not receive the needed substance use disorder treatment that they need. And this was over 12 years by race and ethnicity. So I think the one starkly clear thing that we see is that everybody is not getting the treatment that they need. Like across the board, these numbers are extremely high. But we see in particular, Asian individuals and Hispanic Latino individuals have the highest rates, with the estimated about 96% of them not receiving the needed substance use disorder treatment. This is based on the illicit drug or alcohol use disorder estimates are based on the DSM-5 criteria. And then this is beginning in 2021 with certain questions on prescription drug use or drug use disorder were asked of all past year users of prescription drugs, whether or not they misuse the prescription drugs. So even though substance use disorder is equally prevalent amongst most racial groups, the minority groups experience more disproportionate health impacts. So for example, Latinos experience more severe alcohol problems compared to whites. Blacks and Latinos experience disproportionately high rates of alcohol attributable injury and mortality. And Blacks are more likely to be arrested for drug possession than are whites, although the rates of the past month illicit drug use is similar. And the other thing we'd like to note is that in the counties with more income inequality, the overdose death rates for Black people were more than 2 times as high as in the counties with less income inequality in 2020. And overdose death rates in older Black men were nearly 7 times as high as those in older white men in 2020. So we're seeing a lot of, we're talking a lot about the racial disparities because we have quite a bit of data on racial disparities, probably more than we have on a lot of the other social determinants of health, but that is not to say that there is not intersectionality between all of these. So we know there's some intersectionality between income and employment as well as race. Which brings us to this. So there's several factors that can influence this, including racial bias. As we've discussed multiple times, the disproportionate discriminalization of drug and alcohol use in Black and Brown communities. I would also add to this, there are some place and neighborhood and community factors that play into this as well. Inadequate financial resources, including that lack of health insurance. If you don't have insurance, it becomes much more difficult to access any type of healthcare, yet alone treatment. And then, of course, the stigma within and also, again, against communities of color. We see that all over the country, no matter, which jurisdiction we're working in. There are different types of cultural stigmas depending on the community, depending on the region. There's stigmas that are held against addiction, and they present themselves in various ways. Additionally, non-white populations, they're less likely to be referred to addiction treatment. They're less likely to have the financial resources to pay, and more likely to be diverted into the criminal legal system for illicit drug use and other drug-related crimes. One of the programs that we're seeing popping up all over the country are diversion programs or law enforcement assisted programs, where instead of a law enforcement official arresting someone, they are referring them to treatment, or they're diverting them into some other type of program that would most likely help them as opposed to giving them a criminal record. And so this graph here from the Kaiser Family Foundation is showing how many people pretty much have insurance versus those who do not. So you can see here a majority of folks, non-elderly and low income, have Medicaid. When we look at the non-elderly adults with opioid use disorder, it's almost half and half with the Medicaid and private insurance, and there's about 20% who are uninsured. But then when we look at the low-income adults with opioid use disorder, we see that majority, that 55% have Medicaid and only 13% have private insurance, 13% have some other type of insurance, and 19% are uninsured. So although the Affordable Care Act has increased the benefits that people can use to access mental health and substance use disorder treatment, there are still barriers to obtaining health insurance coverage. And I'm sure you all might have some experience or know of someone who has encountered barriers to obtaining coverage, or having the coverage and not being able to use it for certain things, or just having a bunch of restrictions around what you can do, even if you do have coverage. And so I wanted to show this graphic that kind of, there's no sound to it, but It pretty much shows you the areas in the red square or outlined areas are the areas that have low or no access to buprenorphine, so medication for opioid use disorder. The dark green areas are the areas that have the highest need for that. And then the light green areas are the areas with a high need. So it's going to move. So you can you can pay attention to the whole thing, but you can pay attention to California in particular and see how that looks. Let's try that again. Is it playing?
Yeah.
Okay. So you have this kind of overview of where the highest need is and where the high needs are. And now we're going to see which areas have low or no access to MOUD or doctor's offices. And so there's almost a direct overlap, which is extremely unfortunate. %56% low or no access to MOUD. And so if you'd like to see more information like this is the website that you can visit. And I'll go into some specifics for California. So we talked about the country at large. Now we'll talk a little bit about social determinants of health in California. You know that there's a population of almost 40 million people, where about 40% of that population of residents are Hispanic. We have 1 in 8 people in California living below the poverty line. And this also breaks down racially as well. So Blacks, about 20%, Indigenous, 18%, have the highest poverty rates, which are nearly 2 times higher compared to white individuals at just 11%. 7% of the population is uninsured. There are high rates of overdose death, and I'm going to talk about that in the next couple of slides. So I won't go into it too much now. And I know a lot of folks did not choose education when we talked about the SDOH that might affect substance use disorder earlier, but just for your knowledge, about 16.2% have less than a high school diploma, 20.4% have a high school diploma, and about 34.7% have a bachelor's degree or higher. Some of the other things that aren't listed here include things like housing inequality, which I talked about, kind of how where you live has an effect on your health as well. So there's history of residential segregation, redlining, in addition to income inequality that contributes to whether a person has safe, stable housing. The Census Bureau found that only 41% of Black households own their homes, compared to with over 73% of non-Hispanic white households. And so this will be the last kind of concept we introduced to you all, I promise. I know it's been a lot of like definitions and new things, but we thought this would be important to kind of include. And it's social vulnerability. The name could be a little questionable. We won't lie about that. But I'll go in and explain a little bit about what it means and kind of how public health folks use it. So social vulnerability is referring to a community's resilience or ability to quote unquote bounce back when confronted with external stressors on human health, natural or human caused disasters or disease outbreaks. So it's really kind of about like emergency response. Reducing social vulnerability can decrease human suffering and loss. So the Social Vulnerability Index is a tool that uses census data to identify and map communities that may have more difficulty preventing human suffering and economic loss in a disaster. And so the index examines 15 different indicators, which are grouped into 4 different kind of themes or categories. So one being socioeconomic status, The second is household composition and disability. The third is minority status and language. And then the last is housing type and transportation. And all of this is used to determine socially vulnerable populations. As you can see on this map, where we see low being yellow to the dark blue being high, nearly half of all California counties, so about 40%, so 23 out of the 58, are considered high socially vulnerable areas. Most of them are located within the central and southern part of the state. Coincidentally, nearly half, about 42% of California residents reside within these 23 counties and considered socially vulnerable populations. So as we mentioned in the beginning, you all will have access to these slides so you can kind of dig into it a little bit deeper. But I just want to talk about, like, why is all of this important? All of this social determinants talk, all of these definitions, all of these concepts that we're talking about, why do we care about it when we're talking about addiction and addiction stigma? And as we've mentioned multiple times, you know, in California, overdose deaths disproportionately affect certain population groups. This is a fact. Indigenous and Black individuals are dying from drug overdose deaths at unequal rates compared to white individuals. And this is just taking a look at just race. When we look at income and some of those other factors, we'll be able to see some other types of disproportionate effects as well. So given these disproportionate negative impacts of substance use disorders on racial and ethnic minority populations, it's critical that SUD treatment, I would say SUD programs, whether it's treatment or not, whether it's harm reduction, anything that is working towards improving someone's health should definitely be equitable when we're thinking about that image that Megan showed us in the beginning. And so let's think back to Silas and what we learned, what we talked about him earlier. Growing up, 25-year-old male, grew up in Temecula, Christian household, attends church with his family. Parents live in San Diego, but he moved to Temecula looking for more affordable housing, works in the service industry, enjoys trying new recipes, going to farmers markets, but he doesn't have many relationships outside of his family and has struggled to make new connections. He'll occasionally take a trip back to San Diego to enjoy the beach, but traffic often keeps him from that. He also has an opioid use disorder. 3 years ago, he went through a back surgery and began misusing the opioids prescribed to him for pain management. So again, we're asking the question, what do you think might contribute to Silas's opioid use disorder and his ability to get the help he needs? I'll give you a few seconds, like 30 seconds, to drop your thoughts in the chat. It, you know, might be the same from when we first started, or you might have some new insight on what Silas could be going through. Okay, inequity for people of color. Lack of education, yeah. Economic and isolation and denial, okay. Thank you all. Support, perhaps, lack of insurance, absolutely. And so we have this quote from the RAND Corporation. It says, the root causes of opioid deaths are diverse across individuals. However, they share some common socioeconomic and public health themes, like lack of economic opportunity, financial and/or housing instability, persistent physical pain, feelings of despair, helplessness, and untreated mental health issues. In both the short term and the long term, address those issues directly rather than focusing only on opioid analgesic agents as the cause of harm. Megan, I don't know if you had any thoughts about this quote in particular or about Silas.
Yeah, no, it's I think if we go back to Silas for a second, I think it's useful to, call out like a couple of other additional things. We've got some like really great feedback in the chat. I think a little bit about, he's not in a super urban area. And so if we're thinking about options for care that are most appropriate for what he wants or what he needs, Silas might have to battle that traffic to get to San Diego or get to Los Angeles, because it might not be available in Temecula. He's a Black male, so he is daily experiencing racism and the stresses that come along with experiencing racism. Also, when he goes into a healthcare setting, he is confronted with racism that might keep him from going there, or when he gets there, it might directly impact the quality of care that he's getting compared to his white peers, for example. Thinking about what are some strengths, can we find some strengths in here, or some things that we might be able to build on if we're, if we meet Silas and we're helping him think about what kind of, do you want to enter into recovery? And if you do, what does it look like for you? He clearly, like we said earlier, is a foodie. He works in food. He likes restaurants. The restaurant community or restaurant workers, I think there's a pretty big recovery community in that world. So that could be a place that we might search for. Okay, like, thinking about Silas and what kind of communities or assets and strengths we might be able to build on. If he really loves that world, where can he look for in that world that social support that everybody I think has pointed out in the chat he's probably missing or lacking. He might be religious, sort of unclear here, but there may be support in the church for him, or maybe he finds church to not be a supportive place. He wants to get out, and that's not the place where he thinks he's going to find it. But you can see all of these things sort of creeping into our picture of Silas, and that's how it should be, right? We should ask Silas. We should be working downstream with him on all of these unique social determinants of health strengths and things that might be impacting him negatively, and also be thinking about people like Silas and other folks and how we can be working to upstream to make their experience better. And we've got some more things in here. Recovery residences, absolutely. Affordability of recovery support. Work, absolutely. Long hours and hard on your body if you're working in a vineyard. So really great observations there. That's all, Jody, to add about Silas.
Thank you. And thank you all for your feedback. Real quick, of course, just want to again plug Unshamed California. Feel free to share the content that you're seeing on Instagram, Facebook, interact, comment, like. You can also share your story. And on the website, which is beautiful, there is a section for resources. So you can visit unshamedca.org .org/resources to get additional resources. And of course, if you are someone you know needs help, please visit treatmentatlas.org to get connected to treatment that works for you. And the last slide just has some organizations that you can look into for additional information about health equity and social determinants of health. Thank you all so much. Leslie, I'll pass it back to you.
Yep, thank you guys so much. That was, I've seen this presentation before, and it's still every time I'm like, I learned something new. And what a great way to look at that, Megan, with bringing in that positive, right? Like, what can we build on in order to help people? I think that that's such a good way of looking at it. I know we have 1 minute left. We did have a question around how do we bridge the parts of the stream together, because we know that they're not working separately. We know that we need all of them. So how do we bring it all together to make that change?
Yeah, so I think obviously, I'm going to say this as a community person. I feel like the community is kind of the bridge, because the community lies at the intersection of being the recipients of a lot of the structural work, but then also having direct access to folks who need it. And so I think interdisciplinary kind of approaches tend to work better than just thinking about, you know, just this or just treatment or just prison or just whatever. But when we can combine the two and marry them in a way that is intentional and thinks about long-term effects, we can kind of bridge that gap. Megan, I don't know if you have anything to add.
I agree 100%. The only thing I would add is that's also where there's opportunity for doing innovative research and evaluation to see how those connections and making those connections can amplify impact. And it's hard to research those things, but folks should be funding it and trying to do it.
I'm so happy that that's the note we're ending on, the power of the community, right? Thank you everyone for joining us today. I don't want to keep anyone over too long, but if you do have any questions for us or for either of our presenters, feel free to email us and we will make sure you are connected. Thank you again, Jody and Megan, for such a wonderful presentation, and I hope to see you all next month.